You were the first one 20 years ago who actually recognized that there is a clinical feature of 4H. And she is a professor at the University Hospital at Amsterdam and the Leukodystrophy, and is going to talk to you today about 4H as an overview and the natural history. Welcome, Nicole.
Well, thank you so much. Thank you so much for the kind invitation and introduction, Valerie. I'm very grateful to be here, and for me it's really special. And I think Valerie told you why it is so special. I'm working in a big leukodystrophy center, and I've had the chance seeing many 4H patients from really all kind of severities and also all kind of countries. So I'm also very grateful for that. So although we also do some mechanistic work on 4H, for example with organoids, the talk is really a clinical talk and focuses on what we can learn from looking at patients and what questions we get just from seeing many patients with sometimes very different disease types. So those are my disclosures. I don't really have any conflicts of interests. And I'm also very grateful to the Yaya Foundation for making that possible. It's a rare disease, so we all have to work together. And we have a very pleasant collaboration between Dr. van der Ver, Dr. Bernard, and myself. I'm very happy to say that. And we just took a new photo because I think this one is already about 15 years old. So just to bring us all to the same level, I would like to talk a little bit on myelination and leukodystrophies. I think most of you know it, so just take a little break. So leukodystrophies are diseases, genetic diseases affecting mainly the brain white matter. And in the brain white matter, you have the connections between nerve cells and within the brain and to and from the spinal cord. So there is a lot of traffic going on in the white matter. And you have different cell types. You have the axons, those very thin and long nerve fibers, the oligodendrocytes. Those are the cells making myelin, which is then wrapped around these axons. Astrocytes, it's a bit of help at home, just getting rid of all the rubbish at home. Microglia are brain immune cells, and you have the blood vessels. And in 4H, we concentrate often on oligodendrocytes, although I think we need also to think of other brain cells. So it's really important to understand a little bit on myelination because that process is not going well in 4H, at least not in the classic form of 4H. So we have those myelinating cells, the oligodendrocytes, which are baby cells, baby oligodendrocytes, and then as they mature, they start making those huge sheets of myelin, which are then wrapped around those axons. First, a bit loosely, as you can see it here, and then that is zipped together to a very thick and dense fatty layer around the axon, which protects an axon and also gives fuel to an axon. Because this axon is very long, it can go from here to here, and in a tall person like Ron, for example, it's really, I mean, more than 1 meter long, and that needs really protection and fuel, this axon. And that's all the myelin can provide. So in hypomyelinating leukodystrophies, where we have a lack of myelin, this process doesn't work, and the oligodendrocytes stop working at some stage. So you have this very thin and fragile axon left, and you can imagine that an axon doesn't like it. And over time, the axons slowly deteriorate, and also some of them will disappear. And we think that this is important in disease causes for more hypomyelinating leukodystrophies. So we can see the process of myelination really very nicely on MRI. So when you look here at the MRI of a newborn baby, it's two different methods of taking the MRI photograph. You see that it looks really very different from a child of 2 years old. And that's the white matter, which is a bit whitish here and very dark here when it's fully myelinated. So that's what we can see and follow on the MRI. And when we see children with hypomyelination, 4H or other hypomyelinating leukodystrophies, you see that when you compare a neonate to a normal child, the child with hypomyelination looks very much as a neonate from MRI point of view, because a neonate also doesn't have so much myelin. This happens in the first 2 years, but doesn't happen in children with hypomyelination. So that's the reason why we do all those MRIs, to see whether something has changed. And that's also the reason why we can make the diagnosis of hypomyelination and also 4H with the MRI in many, many cases. So the first description of a patient with 4H has already been end of the 19th century by a doctor called Friedrich Pelizaeus. I think many of you know Pelizaeus-Merzbacher disease because that's the most known, the best known hypomyelinating disease. And it was also discovered by Dr. Pelizaeus. But he also wrote a really extensive description of a little boy. He didn't have MRI at that time, of course, who actually had first a normal development, but then didn't learn to walk properly, needed at some point support when walking, but was very bright, and he had abnormal teeth, abnormal dentition. So although, of course, I can't prove it, I think that this is the very first case of a child with 4H disease described. And then there were two cases, familial cases, when you never know whether this is really a proper relationship or just a chance association. And then we saw the first child with 4H syndrome in 2000, and I was quite puzzled. I was just starting my training in pediatrics and child neurology about the combination of tooth abnormalities and hypomyelination in a child who was able to walk. There were some child neurologists who didn't believe me that it was possible with hypomyelination that you could walk, because everyone had in his mind those patients with Pelizaeus-Merzbacher disease who mostly needed a wheelchair. And then 2 years later, another little girl came in, and she had exactly the same clinical picture as the girl I saw in 2000. And then we actually had 2 more patients collected, and that was the result that we thought that might be really something, this combination of hypomyelination and abnormal dentition. And all those children, all those girls were young, under 10 years, so we didn't make the connection with the delayed puberty, of course. And then some more patients were described, and the group of Dr. Bernard first had that genetic mapping of the French-Canadian patients, and then discovered the genes for 4H syndrome. And now we have 2 mouse models, also the group of Dr. Bernard and the group of Dr. Willis, who are both here and will tell you about it. And then look where we are here, where we are now, thanks to all of you and the Yaya Foundation. We have all those patients with a diagnosis, and now also with a family support group. So although we don't have a treatment, I think there has been a lot of change in the last years. So there are clinical challenges, and it's when I think of the patients with leukodystrophies, with different leukodystrophies, I see that 4H is one of the most complex diseases. We have children with very different clinical neurological signs, patients with very different clinical severity. I saw last week an adult patient who started having first symptoms at the age of 55, a very mild ataxia. So that's also possible, and we have very different MRI features with different mutations. And to be honest, we haven't understood so well yet what the explanation of all those presentations is. So it's a whole kaleidoscope of presentations, and the classic or core presentation we first identified and other groups is hypomyelination, hypodontia, and hypogonadotropic hypogonadism, or the delayed puberty. But you all know that not all children have all the features. But that's in the beginning how the disease was defined. And before you know the gene, you really stick to those very well-defined phenotypes. Other frequent symptoms we also realized early on were the myopia, the short-sightedness. About half of the children are small, and there are also other hormone problems. And the clinical course in most patients was very slowly progressive, although some children had deterioration with infections. And when you look at the MRI of those children, you see the hypomyelination you all recognize now. You see also some small things of other children with hypomyelination don't have, so we can quite nicely make the diagnosis of 4H from the MRI. And what you also see, that's the cerebellum, is the cerebellar atrophy in many patients. So you see here a normal cerebellum, and here a cerebellum in 4H, which looks like a tree without leaves. So those are the main features of the patients with typical 4H, but you can also have hypomyelination without cerebellar atrophy, and also have cerebellar atrophy without hypomyelination, so that's possible. We've seen also quite a few patients with, who have 4H leukodystrophy without having a leukodystrophy. It's perhaps a bit a contradiction, but they have this really normal supratentorial, so really normal brain white matter, but quite pronounced cerebellar atrophy. And I've seen quite a few of them. As a whole group, they are a little bit milder than the patients with the leukodystrophy, but otherwise they're quite undistinguishable, and mostly they have polar 3B variants. Then we have that variant the previous speaker already mentioned, which is intronic variant in polar 3A, so not in the coding part of the gene, but outside the coding part of the gene. And this gives you also not a typical leukodystrophy, and an adult onset neurological disease with mainly spasticity, so stiff muscles, and also ataxia and slow progression. And then you have a disease manifestation which is very striking, and you can also group those patients very nicely together. They have also not a leukodystrophy, or only a very mild leukodystrophy, but you see here those structures which we call the basal ganglia, which are different in patients with this form of 4H than in controls or healthy children. And this is not white matter, this is gray matter on nerve cells very deep in the brain. And this disease is associated with, again, very specific genetic variants. We can say that patients with this variant, and they are really close to each other, next to each other, are usually more severely affected. And they have an early swallowing problem and a movement disorder, a very active movement disorder with a lot of excess movements. The patients with the -6 variant more often have an early normal development and then develop a movement disorder which resembles Parkinson's disease, but with a very prominent speech and swallowing impairment. Some patients are really not even able to speak because they have so many abnormal movements of their mouth and tongue. So this is a very recognizable group which is really far away from the typical leukodystrophy presentation. And just from looking at those patients from a doctor's side, without knowing about genetics, you never would have grouped them together initially as all caused by the same gene. There are also very severe variants. One is Wiedemann-Rautenstrauch syndrome, which is a very early severe presentation, and patients have a accelerated aging process with loss of subcutaneous fatty tissue. Actually, that's something we see in some of our classical patients. The very first patient I saw had a little bit of loss of subcutaneous fatty tissue, for example. So there are some interconnections, and again, we haven't understood everything, or we are far from understanding it. And the very extreme ends of the spectrum are a prenatal onset with multi-organ involvement, for example, also heart involvement, babies who even don't survive or almost don't survive pregnancy. And on the other extreme, the patient I just mentioned, I saw last week, with a very late onset, a normal MRI and very mild ataxia. So all this belongs to POLR3 related disorders, and I think there is still a lot to learn. The natural history, or how is it going clinically wise with those patients? I think something many of you see is that patients can do quite well for a long time, but then at some point, and that's often in the teens, patients deteriorate very slowly. You see also that when you look at MRIs, that you see a very, very slow and mild, but you do see it, a loss of brain tissue. And patients lose, for example, the ability to walk or the ability to eat. And we think that this has to do with the problems the axons have without the myelin. Those are data which are already quite old, almost 10 years old, and that was one of the collaborations across the Atlantic, where you see that when you look at the blue POLR3A patients, they have perhaps a little bit of later onset, but as a group, you see that they are progressing more and quicker than patients with POLR3 variants. I think that we see now also more a little bit more severe patients with POLR3B, but as a whole, that distinction still stands. We don't have systematic new data, and I think it would be really worthwhile to look at what we have now, also formally including patients with, for example, the POLR1C variant, to see how it goes. I mean, 10 years later, we have 10 years more data and many more patients, so it would be worthwhile to do. We have, of course, the involvement of other organs, and there we have some more possibilities to intervene. The myopia, for example, which is usually high, usually early onset and progressive. You know that better than I. Because in myopia or short-sightedness, your eyeball is longer, the retina is stretched, and you have the risk of retinal detachment later in life. And then that can be a sudden onset of discomfort, so you should always also think about the eye when your child complains of headaches, or your child who isn't able to talk gets uncomfortable at all of a sudden. Contact lenses are not always the best option. I think you understand why. We also have patients who have mild hyperopia. not myopia. In my experience, those are mostly patients with polar 3A variants. And later on in life, you can have slow vision deterioration independent of myopia because your optic nerve are also nerve fibers which are not so well myelinated. And that explains the slow decrease of vision acuity you see in many patients with 4H. You have, and that's something we didn't pay so much attention to, I'm afraid to say, behavioral problems. Many children with 4H are very friendly, and I remember the first 4 girls we had with 4H, they all asked me independently from each other whether I had children myself, and it's not something many other children ask me when they have to see me. And some of them really like having their bloods taken. I don't know whether that's, some of them hate it, but some of them love it. So I always have, for a couple of patients, I always have to think of what could I do today to make them happy. Many have mild to moderate cognitive impairment. I think there are quite a few children with autistic traits. Parents describe a repetitive behavior which can be very irritating, like a broken record I often hear, and I see you nodding. And there are quite a few children who can have really, really violent temper tantrums. Yes, and I think that this is something we really have to know more about it, because it also helps when you know what to expect and how you can deal with it. And there are other problems, fatigue. It's frequent in patients from their teens, and it can be really a huge problem. Of course, you all know about bone health. We have, of course, the problem of osteoporosis or low bone density because of the lack of sex hormones in patients with delayed or absent puberty development. But you have also a few patients who have in the beginning increased bone density. And we think that's a defect of osteoclasts. Osteoclasts are the cells which break bone. In our bones, the bones are all the time remodeling. So you lose a little bit of bone tissue, you make a bit of extra bone tissue, which is very important for bone health. And this breaking of bone tissue, we think is perhaps affected in 4H, and that I think might explain the dentition abnormalities. I had a PhD student some years ago who tried to measure osteoclast function, and although he put a lot of effort in, we never managed to do that. You have the impact of infections. I already alluded to that briefly. In some patients, it can be very prominent, and in others, it's non-existing. And you have problems with weight, and that may be both ends. Some patients have low weight and really problems to gain weight, and others have overweight, which may have to do with decreased mobility. And I'm sure you know of more examples I should mention here. So we are always glad if you ask questions, because that makes us think of things we perhaps missed in other patients. So to conclude, I think it's really a very multifaceted condition for 4H leukodystrophy and the related polar 3 associated disorders. The precise genetic variant can be very important for the clinical presentation, but also there is considerable intrafamilial variability in some families, and probably also external factors like infections influencing disease severity and also disease progression. And the knowledge of the different forms and the natural history in those different forms is essential for good clinical trials in the future, but also now for counseling what you can expect of the disease in the next years for your child. Don't forget a role of symptomatic treatment, better description of the behavioral traits and the involvement of other organs. So a child neurologist or adult neurologist is not enough for a child with 4H. And I think better understanding on what's the basis actually of the neurological problems. Is it mainly the myelin problem, combination with the cerebellar atrophy, or the cerebellar atrophy, or perhaps also a problem of the cortical neurons? That's also very important to keep in mind when developing treatments. I didn't mention some other observations we made, for example, epilepsy, that is, in my experience, more frequent in children without hypomyelination, and we don't know why that is, again. So that's, you see, it's still a lot of work to do for all of us. I would like to thank you for your attention, and all patients and families for asking, coming, and now being here. All the referring physicians, especially in the first years when I was a junior doctor just starting, and they helped me to identify more patients. Mayo van der Knaap, who founded the White Matter Center in Amsterdam, of course,